All right. We're going to go ahead and keep moving with the schedule. So next, we're going to have Dr. Ken Moise talk to us about red cell alloimmunization. I'm sure everyone here knows him. Pretty much every chapter, every piece of literature on the topic has been written by him. And those of us who eventually once wanted to write about it, we didn't because he had already written it. I know him for a long time. He's currently a professor at Dell Medical School in Austin, Texas, just recently moved there. He also serves as the director of Comprehensive Fetal Care Center at Dell's. His interest in fetal therapy spans over 30-year plus. He's recognized worldwide for his contributions in fetal treatment of RH disease, including the development of what we use every single day, which is the MCA Dopplers for non-invasive diagnosis, and use of fetal-free DNA to check RH status and other antigens on fetuses. In 2019, he was awarded the Lifetime Achievement Award by the Society for Maternal Fetal Medicine for his work in hemolytic disease of the fetus and the newborn. So it's a real honor to have you here, Dr. Moise, and go ahead.
Well, thanks for the invite. I appreciate this. This is sort of my favorite topic to talk on because it's what I've spent most of my career, emphasizing. As far as disclaimers, you're right. I was once told if you should pick a niche in academics, work on just that area, write the peer-reviewed papers, and eventually they'll ask you to write the book chapters. What they didn't tell me at the end of that is then the pharmaceutical companies will find you at that point. So that's kind of where I am in my career. As we begin to move further into novel treatments for this disease, I will be talking about one drug that I will share with you that I think is very exciting, nipocalimab. And it's still investigational. It's not for clinical use. What I want to do today to talk is about a couple of things. I want to help you understand how we detect fetal anemia, understand some of the advances in the treatment. I think it's always interesting to look at the history of where we were and where we are today. And then we'll talk a little bit about the rationale of nipocalimab and FcRN blockade for the treatment of the disease. This is a graph of what's happened to rhesus disease. It stops in 1990 because the CDC no longer required reporting on birth certificates in the U.S. And you can see that we've seen a dramatic decrease in the disease with the advent of rhesus immune globulin postpartum back in the late 60s. And then later in 1981, the American College of OBGYN suggested we also give it antepartum, but we've seen a plateauing of disease. What we have also seen is that there are other antibodies that we have no prophylactic immune globulin for that continue to occur in women, in up to 1% of women in this large series that came out of Holland. And it turns out there's probably about 4 different antibodies that can cause significant enough disease to affect the fetus. Now, there are over 50 antibodies that have been associated with HDFN that can cause high bilirubin in the neonate, but when it comes to fetal disease, if you remember the mnemonic deck, it's D, big E, little c, and Kel, or K1, are the big players, or the bad players, if you would, that can cause significant disease in utero. So it's not just D, and we're never going to have this disease go away in our lifetime because, as I mentioned, we don't have prophylactic immune globulins for these other antibodies. Now, it was in the 1960s that we began to see an effort to determine how the baby was anemic. How did we find an anemic fetus? And this is a picture of John Lively, Sir Professor Lively from New Zealand, who came up with the idea of checking the amniotic fluid for what was called at the time delta D450, or the amount of bilirubin, an indirect answer to hemolysis. And then a little bit later, when a young Italian man named Giancarlo Mori was working with me as a fellow in Houston, he came up with the idea of looking at the speed of the blood in the brain. Now, he looked at every organ in the body, in the fetus, trying to figure out the optimal vessel, but it turned out that the middle cerebral artery Doppler and the peak systolic velocity was associated with fetal anemia. So he would do the Doppler findings, and then we would take the patient to transfusion, get a fetal hematocrit. He would correlate that. And in the year 2000, which seems like yesterday, but it's 23 years ago now, he published this New England Journal of Medicine paper to suggest that the MCA Doppler was a non-invasive way to detect fetal anemia. So we no longer had to do amniocentesis and look for bilirubin in the fluid. And I remember I think it was one of the LabCorp directors called me a few years after this paper and said, "No one's ordering Delta Ds anymore. Can I throw my machine away?" I said, "Shut it down. We don't do that anymore." So this has sort of become state of the art. And the truth is, this is probably one of the biggest breakthroughs, in my opinion, in the detection of fetal anemia, and probably saved more babies from having amniocentesis and the complications thereof, because these women had to go amnios every 7 to 10 days. So you might do 6 amnios on a patient, and now we don't do any, so we use ultrasound. Dick Opkes out of Leiden a few years later did a randomized trial to prove the observational trial of Giancarlo and showed that it was superior, MCA Doppler was superior to amniocentesis. And I was asked to write the editorial that accompanied it. Whenever you write an editorial in the New England Journal, you try to stay up late at night and come up with a catchy title. So I came up with "It's time to put the needles away." And in fact, that was true. So we no longer had to do Delta Ds and serial amnios because MCA has sort of proven its worth. And now it's state of the art. As I mentioned, no one does Delta D450. The next issue, the next big advance came with the cloning of the RHD gene, and it was actually the first free DNA test done. People think we did non-invasive prenatal testing for Down syndrome, but in fact, Dennis Lowe at Oxford was the first to detect RHD sequences in the maternal circulation, which led him later to become interested in Down syndrome and detection of chromosomal anomalies. And so we know, at least for RHD, almost half of dads are heterozygous. For KEL, it's 98% of dads are heterozygous, which means you have a 50-50 chance of an affected baby. And then we are often faced with unknown paternity or questionable paternity into whether the baby carries a particular antigen that's the maternal antibody is going to affect. And so in the past, amniocentesis was state of the art, where we would simply do another amnio and check for fetal DNA and determine the baby's blood type through DNA analysis. And that couldn't be done until 15 weeks. It had consequences of increased alloimmunization. If you hit the end of the placenta, you could get back bleeding and cause an amnestic response in the mother's titer. And so we now know that there's free DNA from the placenta. We now know it comes from the placenta through apoptosis that's shed into the maternal circulation, and it can make up 5 to 10% of the entire DNA pool that you find in the serum during pregnancy. And obviously we can analyze that and even compare it to the maternal DNA to determine the baby's blood type through genotype testing. And this was a large study we did with the Sequenome group to look at free DNA and RHD typing, and we actually compared it to serology at birth. So this was a pretty cumbersome study to try to get serology back on every baby, where we had determined free DNA during the pregnancy. And we only found one mistake in the entire group as far as a false negative. And it turned out to be a laboratory error in the way the samples were labeled. It really wasn't a genetic error. So this is a fairly accurate way to tell that what the baby's blood type is. Because if the baby's Rh negative, we can stop testing. We don't need to do titers. We don't need to do MCA Dopplers. We can just stop. And now, this test originally was available in Europe first, and the Sanguine lab was known in the Netherlands for this, in Amsterdam, and they did all the different antigens. But now the US has developed a laboratory that most recently, using sequencing, is also able to do the various DNA typing on free DNA in the mother's blood as early as 8 to 10 weeks. And in the case of a heterozygous dad or an unknown paternity, you can determine if the fetus is at risk. So this is a big breakthrough, and that we're finally following up what the Europeans have been doing for some time and starting this in our country. So next I want to talk about how we treat a fetus. Once we determine it's antigen positive, and the MCA Doppler shows that the fetus is at risk for anemia. That's usually a threshold of 1.5 multiples of the median for the velocity. That's what we found originally to be a threshold for detecting fetal anemia. We have to try to do something for the fetus. And the first person, again, was Liley, and I always used to erroneously say he was from the country of Australia, but it turns out he's from that little island next to it, New Zealand, and he just happened to be in the right place at the right time. Liley's on the right at the Auckland National Women's Hospital. On the left is Liggins, who came up with steroids for lung maturity. So two of the most major advances in our field came from these two gentlemen on this little tiny island. And Lally was, although he was diagnosing these very sick fetuses with delta D450s on amniotic fluid, there was not much to do. And so he realized that perhaps he could take a needle and direct it into the peritoneal cavity of the fetuses. And here you see his first report. After 3 of the babies died, it was the 4th pregnancy that he was able to succeed in doing 2 transfusions and have a live baby by putting blood in the peritoneal cavity. This is anticoagulated blood, so it's picked up by the diaphragmatic lymphatics. It enters the fetal circulation, and in fact was a successful technique. And I had the opportunity to visit the Women's Hospital in Auckland and actually see some of the original radiographs from Lally. I'll share with you. He didn't have ultrasound. He had fluoroscopy and x-ray, so he would do things like lay scissors down on the abdomen to mark where the fetus was, and then sort of blindly stick a needle into the peritoneal cavity of the fetus, and under fluoroscopy inject dye to say, oh, my needle's in the right place. And then he would inject blood into the fetal abdomen to treat these fetuses. Later he learned that he could actually take a catheter and thread a epidural catheter through the needle and place the epidural catheter into the fetal abdomen and inject the blood through the peritoneal, into the peritoneal space through that catheter. And actually I remember when I first came to Houston as a fellow in the mid-'80s, we were doing that. We were putting large needles into the peritoneal cavity, running an epidural catheter inside, putting a few extra loops so the fetus wouldn't pull it out. And then we would, my job as the fellow at the bedside was to then hook the blood up to the catheter, push the blood into the belly, and then pull the catheter out. And that's how we did transfusions in 1985. People tried some more invasive approaches and said, well, what if we could get direct access to the fetal circulation? And there were a couple of cases of hysterotomies done, particularly in South America, where they would try to gain access to a leg or an arm and actually cannulate a vein and give blood directly to the fetus, which made sense because you really wanted to get that hematocrit in a reasonable range fairly quickly. Most of those failed because of preterm labor, and so those efforts at open fetal surgery to transfuse babies were abandoned. And it was John Hobbins who then told us later on, well, we shouldn't be using fluoroscopy, ultrasound's getting better, we should use ultrasound to guide our needles. And here you can see in the 90s where he began to introduce ultrasound to begin to guide the needles to do transfusions in the baby. The first direct blood given to a fetus by ultrasound was given into the intrahepatic vein, and that was done by Jez Bang here in 1982. And you can see that blood could be given directly, and to this day, we still use the umbilical vein, intrahepatic umbilical vein, as a target, an access point to put blood into a fetus. And that's pretty much used widespread in both England and Europe as compared to the US. The US likes to use cord insertion, so typically we look at where the umbilical cord inserts into the placenta. This is from the group in North Carolina that first reported this access point. And so standard of care today is an intravascular transfusion. So MCA Doppler says we have an anemic baby. We go to an intravascular transfusion by putting a needle into the umbilical cord and pushing blood directly into the cord. Now when you do that, the baby moves a lot, and that can be disconcerting because it doesn't make your procedure any easier. And it was the Australians who introduced us to paralytic agents being given during the procedure. And so again, state of the art today is to gain access to the fetal cord, take a small sample of blood. We have a hemocytometer outside of our OR where we can check the actual hematocrit. And then we use vecuronium now, not curare. We give it intravascularly, and they get a little dose of vecuronium, and the fetus stops moving. And then based on the fetal weight, we can calculate an increment we want in hematocrit, and we can transfuse the fetus directly. So that's state of the art. Even in 2023, that's the only treatment we have for this disease. In experienced hands, a survival rate can be as high as 90 to 95% with the use of serial intrauterine transfusions. Unfortunately, we don't do one. The average is 4, and it can vary based on the severity of disease. The earliest we can do them is around 20 weeks, and the latest we do them is at 35 weeks, and we try to get our patients delivered around 38 weeks. But we are still faced with a problem when the patient presents with very early disease and very high titers. Because even then, the cord is so small that trying to get even a 22-gauge needle into the umbilical cord is technically impossible. And these fetuses are so fragile. They weigh on the average of 250 grams to 300 grams. They just don't tolerate having intrauterine transfusions done. And if you look at the data on transfusions done before 20 weeks, where these vessels are so tiny and these fetuses are so friable, the loss rate is as much as 4.6-fold higher than later in gestation. So a lot of us in this area were like, well, is there a way that we could buy time and try to get these fetuses further into the pregnancy? Well, we know we have bigger vessels, and we know technically we can do a better job in getting blood in them. We did find in some cases that you can actually go back to the old technique that Liley did and put blood in the peritoneal cavity of these babies. And it turns out it gets absorbed. And for some reason, the lymphatics of these babies work very well early in gestation. All the old formulas that Liley and John Bowman put out there don't work below 20 weeks. It says you would give a negative amount of blood. So you put a little bit in and you kind of look at it. But it turns out it gets absorbed. And so those of us who've been doing this for a while have used this as a bridging technique to get enough blood into the baby until later in gestation, when again the cord is a reasonable size that we can gain access to it. So there are several reports, mostly anecdotal, of people using intraperitoneal transfusions early along as a bridging technique to get the baby big enough to do intravascular transfusions. That being said, I think there is a general, after this PETIT trial was published back in 2018, that there's a general consensus among the fetal medicine folks that deal with these diseases that IVIG is a method of immunomodulation that perhaps can buy time to get these babies far enough into gestation to do intrauterine transfusions. And this was the largest series published of 52 patients at 12 centers, including some data from our center. 24 of the pregnancies were treated with IVIG, and 28 were not. And what you can see is a difference in gestation. Although it didn't reach statistical significance, it was 15 days later in gestation when IVIG was used, and 9 days earlier. This is compared to their previous pregnancy. So if you compare their subsequent pregnancy to their treated pregnancy, it looked like IVIG bought you 15 days, whereas if you didn't give IVIG, you were doing the transfusion in the subsequent pregnancy 9 days earlier. And you can see differences in some of the other parameters. But what came out of the study is you have to start it early enough. So we know IgG begins to cross the placenta at 10 to 12 weeks of gestation. And so if you start the IVIG at less than 13 weeks, you might gain as much as 3 weeks compared to the previous pregnancy, and do it much later. And you'll get a reduction in the number of transfusions that you do prior to 20 weeks. So again, those of us that see these, what we call early onset disease, these are patients who've had losses or maybe intrauterine transfusions before 24 weeks, we will offer them IVIG in the subsequent pregnancy, starting as early as 13 weeks. We use a pretty impressive dose. We give them 1 gram per kilo every week, which it comes with its inherent issues of headache, hemolytic anemia, malaise, and all these other things. So if, as a hematologist, you may be consulted by fetal medicine to say, I want to start IVIG and here's why, and they may quote this PETIT trial. More recently, just last year, the Canadians put out similar data, almost an identical group of patients, and when compared to their previous pregnancy, they noticed a gain of around 16 days. It doesn't sound like a lot, 2 weeks, but it makes a big difference between, say, 20 weeks gestation and 22 weeks. And even then, when they went in to get the initial hematocrit compared to the control pregnancy, which was the patient's antecedent pregnancy, the hemoglobins were much higher in the treated pregnancies. So the take-home message here is IVIG buys you time, but it doesn't totally treat the disease. These pregnancies are still going to need to be treated with intrauterine transfusion, but hopefully at a later gestational age where that success rate goes up into the 90 to 95% range. We don't know how IVIG works. There's been at least 3 proposals. One is it does seem to temper the maternal antibody production through a biofeedback mechanism, It may well saturate the placental FC receptors, sort of a smoke screen, if you would, and not allow as much anti-D or deleterious antibody to cross. And it does actually cross the placenta, and it may create some type of reticuloendothelial blockade in the fetus. So we're not 100% sure of how it works, but it seems to, again, buy time and ameliorate the disease to some extent. So I want to finish with where we're going, because this is sort of a shotgun approach with IVIG. It's very expensive. There are a lot of complications to it. We always give our patient the initial dose in-house, and then we do it as an outpatient, either at an outpatient infusion center, or we use home therapy quite frequently. I don't use hematology. I usually manage it myself. We've learned a lot of tricks about the headaches, including giving some antenatal steroids sometimes before the infusion. We found that both Reglan and Imitrex work very well for the headaches. Our migraine patients taught us that. And so we will use Reglan or Imitrex to treat headaches. And usually the headaches are limited to the first few infusions, and then it seems to wane after that. We also worry about the patient that's blood type B, because we know that some of the lots contain anti-B, and so we worry that you can get a hemolytic anemia. So if we have a type B patient, we will check their hematocrit periodically, being concerned about any degree of hemolysis that might occur due to the IVIG. So where are we headed? So it turns out that nipocalimab is a monoclonal antibody developed by a small company, a small biotech firm in Boston, subsequently purchased by Janssen Pharmaceutical, that's specific to the neonatal Fc receptor. And it turns out the Fc receptor, as you're probably aware, has two mechanisms. One, it maintains your circulating pool of IgG, and secondly, it is paramount to the transport of IgG from the maternal circulation to the fetus. So if you look at the little blue diagram here, the little blue objects, that's the FcRN receptor blocker. You notice that if you attach your antibody, and in this case the red antibody is going to be the bad antibody. I'm sorry, the Nipo is the blocking antibody, the blue is the FcRN receptor. Both IgG that's normal and the yellow pathogenic IgG can be attached to the FcRN. And so you push more of your antibody over to the lysosome, and you cause degradation of your total IgG pool, both the pathogenic IgG and your normal IgG. So in essence, you lower the serum levels of total IgG by administering the FcRN receptor. As a secondary mechanism, it blocks the passage of antibody across the placenta. It's not selective, though. It blocks both pathogenic and it blocks the normal IgG from crossing the placenta. The nipple, it turns out, does not cross the placenta. It stays attached to the fetal side. So it looks like this. So this is the regular IgG attaching to the FcRN receptor. And what you see to the right is Nipo, which used to be called M281, attaches at a little different site, but in essence, it blocks it completely. So the IgG cannot be rescued by the FcRN receptor, and it can't be transported across the placenta. As in any FDA approval process, this was first performed, it was given to cytomolgus monkeys, which have placentation very similar to the human, and with extensive studies done in the monkeys, there were no issues with safety determined in the pregnancy or the neonates. The FDA actually had them deliver these neonates and take them out to 6 months of age to test them for infections and other issues. It was done in vitro studies. I think these were actually done in Galveston with an in vitro placental model, which is a turned placental model, to actually show, as you see on the right, that although you get significant levels of Nipo in the maternal circulation, at least in this model, there was virtually no nipple that crossed the placenta. So it stays on the maternal side of the circulation and doesn't cross, which would be a good thing. So the concern, of course, in any clinical trials would be, well, could the mother develop infection because you're lowering her circulating IgG pool? And if you're stopping the transfer of IgG across the placenta, then what about the baby? It no longer gets the benefit of maternal IgG. And so those are the issues that have come up. It doesn't seem, this particular FcRN receptor blockade doesn't affect other classes of antibodies, so it doesn't affect IgA, E, or M. It doesn't affect the production of IgG, it just drops your circulating pool of existing IgG, and it doesn't seem to affect your T cell or your NK killer cell function. So in principle, it shouldn't cause a patient to get a higher risk of infections. Interestingly enough, the FcRN receptor is associated with albumin recycling also, so you would expect to get some albumin declines in pregnancy as well when you give this to a pregnant woman. Know that albumin naturally falls in pregnancy anyway. So you're probably aware of this, but FcRN receptor, or a FcRN receptor, has now been approved by the FDA back in December 2022. It's used for patients with myasthenia gravis who have are antibody positive to the acetylcholinesterase receptor, and it's proven very effective in those patients. It's given intravenously once weekly. Subcutaneous trials are ongoing, and here you see a variety of autoimmune diseases that are being evaluated in various trials right now with different FcRN blockers. So NIPO is just one of many. To my knowledge, NIPO is the only FcRN receptor being evaluated in a pregnant situation at this time. So the phase 1 trial was done actually in the Netherlands with normal human volunteers, and what you see is that at about 3 weeks after starting weekly infusions, your total IgG pool drops to about 15% of normal. Despite that, during this time, these volunteers were followed during the flu season for any kind of infectious complications, and there were really none. And so despite this significant drop in the circulating pool, it seems that these individuals are still competent, immune competent enough to fight off infection. So a phase 2 trial was designed and was just completed. I can share with you that. I can't tell you all the data other than the fact that it looks very promising and that will be published very soon, and to the point where Janssen Pharmaceutical is working on developing a phase 3 trial, a randomized clinical trial to get FDA approval. But in this trial, which was limited to 15 patients with very severe disease, either their babies had to have died before 24 weeks in a previous pregnancy, or they required transfusions before 24 weeks. So we had what we called early onset disease. Those were the ones allowed in the trial. There were, I think, 14 international centers enrolling these patients. It took 3 years, mainly due to COVID, that we were able to finally complete the patients. No safety concerns came out. You can see the patients are screened fairly early, and the drug is started around 14 weeks and infused every week. And then the patients were delivered at 37 weeks, and the moms and babies are followed out. The babies are followed out to about 3 or 4 years of age. But at this point, there have been no safety signals either in the mothers or the babies in the trial. And what I can tell you from the efficacy point of view, because I think there was a public release of information by Janssen, is that we met the primary endpoint of no transfusions and all live births after 32 weeks. And so at least in this very high-risk group of patients, this looks very promising. And again, a phase 3 trial is being designed. I think it will probably start sometime this summer as a randomized clinical trial in patients with a history of any IUT in the past. So that's the plan for that. So I love to show this picture because it's from North Carolina, and it's from the movie Last of the Mohegans. And I really hope that I will be one of the last of the Mohegans who puts needles in babies and pushes blood into babies, and that this drug will be the medical treatment for this disease and for the future. And I always finish with this because my daughter tells me I have to do this. She has formed this podcast with me. So it's a father-daughter podcast you're welcome to try to find. It's called News Womb, and we affectionately call our followers womb mates. And she came up with that catchy time. It's on all the different ones. But we basically realized there was no podcast for fetal medicine. And so for those of you interested in further information on rhesus disease, there are about 8 chapters that we've already put out on rhesus disease, including one just on the use of IVIG and our experience in pregnancy. So you're welcome to listen in and gain some more knowledge. But thank you for your time today. I appreciate the opportunity to talk to you.